About a very specific and specialized treatment for keratoconus. Now, as very nicely has been explained by Professor Tityal sir, that keratoconus is a disease wherein you have a conical protrusion of the cornea becomes steep. So the idea is to flatten it. And that is why these intacts are segments, arc-like segments, as you can see here. These are made of PMMA, polymethyl methacrylate, and these are inserted in the peripheral part of the cornea so as to cause a flattening of the central part of cornea and to correct the myopia and astigmatism associated with keratoconus. Now, just briefly, I will tell you how it works. Basically, this is the a segment which is inserted into the corneal stroma. So it separates the corneal lamellae. It is inserted at the level of 70 to 80% of depth. And what it does is, as you can see here in the picture down, that it shortens the arc length. So it shortens the arc length of the cornea within the intact segments. And that is how it causes flattening and results in correction of some degree of emmetropia in keratoconus. I'll just show you a small video clip how it is done. The center of the cornea is marked. And once you mark the center of the cornea, this is the femtosecond assisted creation of track. So within the cornea, you have to create a path through which you can insert the ring segment. And that is what is done either with a mechanical separator or by the use of laser, which is femtosecond laser, as it is being done here. So as you can see here, the path is being created. And this is a radial incision that has been made through which these intact segments are introduced. So the first initial part, the path is separated by a separator. And once it is done on both sides, then you place the intracorneal ring segment into this track, and it is progressed forward. So on one side it has been done, and then the same way it is done on the other side. And after doing both this, extremely sorry for this. After doing both the sides, you put a suture to close this incision. And then in cases of keratoconus, you debride the central part of epithelium within the area which is there within the intact segments. And then you do crosslinking. A detail of crosslinking will be discussed by Dr. Namrata. And this is how it looks like in the post-op period. These are the intact segment. And what happens that the central arc length is shortened. So it is flattened, and thereby by flattening, it reverses the steepening that is there in the disease called keratoconus, and thereby bringing about some correction in the emmetropia created by it. Just a few words about the planning of the surgery. It depends on the type of cone. Cone can be centered cone or decentered cone. If you have a centered cone, then in that case, you put symmetric segments. And if you have a decentered cone, you put asymmetric segment, means the segments are of different thickness so that you create correction differentially. Just an example, a case of -4 diopter sphere and -4 diopter cylinder at 40 degree. So in order to decide about the incision, you convert it into positive cylinder form. So -8 diopter cylinder with +4 diopter, -8 diopter sphere with +4 diopter cylinder at 130 degrees. So the incision will be put at 130 degrees. So here is the incision. And since the posterior float shows that the cone is central, you can put a symmetric cone. Another example, you can see here the float is showing that this is an asymmetric cone. And in such cases, it is better to have a differential treatment. So you put a thicker segment, you put an asymmetric segment. So a thicker segment is put here and a thinner is put here. So as to create a differential treatment and correct astigmatism. Sometimes in an asymmetric cone, you also put a single segment. Like in this case, a single segment has been put. This is the incision, and this corrects the irregularity that is seen in cases of in corneas in cases of keratoconus. So in conclusion, intracorneal ring segment is a specialized treatment which is done in cases of keratoconus to regularize the surface, to flatten the central part by inserting one ring segment and flattening the central part of the cornea. And it is combined with cross-linking so that once you regularize the surface by putting the ring segment, you can stiffen the cornea by use of corneal cross-linking. And that's how you bring about the visual rehabilitation by further means, by contact lens, etc. But you correct a significant degree of ametropia, particularly astigmatism in cases of keratoconus by intracorneal ring segment. So thank you very much for your patience.
So thank you, Rajesh. I would now be speaking about the collagen cross-linking. So I would be talking to you about collagen cross-linking in corneal ectasias and surgery. And the corneal ectasias, like has also already been discussed, can be primary, that is keratoconus, where you just have a cone, or can be keratoglobus, where you have the whole of the cornea which becomes globular, or it can be thinned out in some parts and not thinned out or curved out in other parts, when we technically call it pellucid marginal degeneration or Terrien's marginal degeneration. Alternatively, even it can occur after surgery. So it can occur after various refractive surgeries, as has been shown here, and after corneal transplantation procedure also. Now, this has already been covered, so I will not be covering this. Basically, I'll be talking to you about collagen cross-linking, which is the treatment modality for progressive keratoconus at early stages. And this is a procedure which stabilizes the progression of the disease. It has excellent safety profile, which has been proven in adults. And now there are many studies and literature in the last 10 years or so to establish that it is a safe procedure and it is an efficacious procedure. Now, it is important to understand that collagen cross-linking halts the progression of keratoconus. Whatever keratoconus is occurring at whatever stage it is, it cannot treat it. It just prevents further progression. So if we look at the normal corneal stroma, there are collagen fibrils or bridges which are present in between. And in keratoconic corneas, there is distorted arrangement, as was very nicely shown by Professor J.S. Tityal sir. And also there is reduced tensile strength. So what we are planning to do, or what we aim to do, is increase these crosslinks so that the cornea becomes more stable. So riboflavin excitation is done and photoactivation is done with the UV light. So it releases reactive oxygen species. New covalent bonds are formed, which increases the biomechanical resistance of cornea by more than 330%. Now, it can be done only in some cases of keratoconus. It cannot be done for all cases of keratoconus. And we generally do it when there is a progression in keratoconus, although there are some situations in which we will do even when the documentation of progression is not there. So like has been shown previously, the patient undergoes corneal topography, and whenever there is a change in keratometry value of more than 1 diopters over 1 year, or in cylinder of more than 0.5 diopters, or when there is corneal thickness which decreases over a period of 1 year more than 20%, then collagen cross-linking is indicated. However, if your cornea is very thin, less than 350 microns, or if there is a scar present, or if it is severe dry eye, or immunocompromised patients, or other diseases like collagen vascular disease, or history of poor wound healing, or riboflavin allergy, then in those cases, we cannot do collagen cross-linking. This is again to show the same. What is initially done is that you debride the epithelium, and after debriding the epithelium, the riboflavin is instilled, following which the UV radiation is given. This is essentially, you can say, it is actually not a surgical procedure. It is just radiation followed by preceded by epithelial removal, which is just the skin of the cornea, which is removed. Now, there are various protocols that we follow, and I think this is too technical, but these protocols are followed depending upon the indication, depending upon the surgical time that is there. And this is again briefly to show you how it is done. So this is the skin of the cornea that is just removed. And then after this, the riboflavin, which is yellow in color, is instilled. And this is so that the UV radiation can occur on the cornea, and also so that the deeper layers of the cornea are protected. Now, after this, the UV radiation is given. And even when the UV radiation is given, this is just to show that riboflavin drops have to be given. This is followed by the application of the bandage contact lens at the end of the surgery, following which the patient is discharged. Now, generally, we can tackle with one eye, and we generally do the worst eye first, provided that the corneal thickness is adequate, followed by the fellow eye, which some people like to do it after some gap, and some people like to do it together. Now, after collagen crosslinking, it is important that you do not rub your eyes at least for the initial 5 days. Then you may notice that there is increased sensitivity to light and there is a foreign body sensation. Patients may also notice that there is discomfort. If there is any severe pain or sudden decrease in vision, one should immediately contact the treating eye doctor. And if the contact lens falls down or becomes dislodged, then one should not replace it, but you should immediately contact the treating doctor again. And it is important to know that there may be some discomfort during the healing time, when it takes about a week for healing to occur. And there may be some foreign body sensation, gritty sensation, or burning sensation. Generally, we can do conventional cross-linking, but some of the corneas which are thinner, you may have to do different kind of a procedure where we do cross-linking, but we use various aids. Like we would use a riboflavin dye, which is hypoosmolar and not isoosmolar, or we would do a contact lens assisted cross-linking to increase the corneal thickness, or several other methods like donor cornea assisted cross-linking. I think I would not go into the details how these are done. Suffice it to say that we increase the corneal thickness by various mechanisms and then do the cross-linking. Now, it has been shown that there would be corneal flattening of up to 1.4 diopters or even up to 1.7 diopters in some of the studies. In an odd case, there may be also increase in the curvature of the cornea, but by and large, there would be flattening. And in the initial part, there may be corneal thinning, but later on, it becomes quite stabilized. Collagen cross-linking procedure on an average would last you for about, say, 6 to 8 years, because the collagen turnover is about 8 years. Some of the cases you may not need to repeat, but again, in few cases, say in about 10% of the cases, you may have to even repeat the procedure. In the follow-up, you give antibiotic drops, lubricants, then bandage contact lens is removed on day 3 or 4, and then follow-up is generally done at week 1, month 1, 3 months, 6 months, 1 year, and then yearly thereafter. In children, we would like to follow up at a shorter interval. And when you're also monitoring for progression, for children, you again would want to follow up at a shorter interval of 3 months as opposed to 6 months, which we do in case of adults. Now, when there is thinning, which is there extensively, the patients are contact lens intolerant, there is presence of corneal scar or corneal opacity or whitish cornea in cases of keratoconus, then you may have to resort to corneal transplantation. Corneal transplantation is something that should be deferred for as long as possible, because that requires a lifelong follow-up. And this is just to show that some of the cases you can do the partial replacement of the cornea. So only the, not the entire cornea, but only say about 250 microns of the cornea is removed and replaced with 350 microns of the cornea. So the total becomes a normal thickness cornea, which is about 500 microns of the cornea. And this is sutured with the 10-0 monofilament nylon sutures after removing the diseased cornea. Now, at times when it is really thinned out, you may have to go right up to the edge and remove almost 90% of the cornea, but still about 10% would remain, and you would do a procedure which is outside the eye and not enter the eye. This is just to show the pictures when the sutures are still there, and after removing the sutures, only thing that you see is a suture line there, and there would be no sutures. Now, when it is very severe, you may have to remove the entire cornea and replace it full thickness, as is shown here. But this is done in very severe cases, as has already been described earlier, that you can have mild, moderate, and severe keratoconus. You can again have pellucid marginal degeneration, where the thinning and the curvature changes only peripherally. So that can be treated with contact lens or with Intacs or with corneal transplantation. Now, this is just to show that thinning was present only in this part. So this part is only being reinforced, and the rest of the cornea we are not trying to reinforce, except that we are putting a partial thickness cornea. And this is how it will look after putting the sutures, because the peripheral part of the cornea is also thinned out, apart from the central part of the cornea, which is thinned out in keratoconus here. This is to show how when you have a whitish cornea, you may have to replace it completely, because you may not get past this whiteness after you do a partial thickness replacement of the layers. Now, something that we are doing, and I'm sure Dr. Praveen will also be talking about this, is the biosynthetic cornea, in which a pocket is made with the help of the femtosecond laser. And then this bioengineered or biosynthetic cornea is taken, is folded inside, which looks very much like a contact lens, and then is placed inside. And this procedure does not have any sutures at all. So, and this is followed by the bandage contact lens placement. So we've actually tectonically stabilized the cornea, because we've added thickness to the cornea. And additionally, you can also cross-link it so that it does not progress further. Again, after a corneal transplant, you would give antibiotic drops, steroids, lubricants, and follow-up. Follow-up is almost lifelong, and also you may need to follow up more frequently for removing the sutures. So to conclude, as far as collagen cross-linking is concerned, one must understand that it halts the progression of keratoconus. It is done when corneal thickness is still adequate, more than 400 microns, and repeat procedure may be required in about 10% of the cases after 8 years. It also depends on what time you are having collagen cross-linking. If it is done in a child, for instance, you may require a repeat procedure. But if it is done, say, at the age of 20, 21 years, you may not require repeat procedure. If thinning is not adequate, then different protocols can be used and different methods can be used, which is more for us to know, especially the technical details thereof. And in cases of excessive thinning, severe ectasia, and whiteness of the cornea, corneal transplantation may be done. This can be partial thickness or this can be full thickness, depending upon where the level of opacity or the whiteness is. So thank you very much for your kind attention.